Thank you for joining us for today's Nevada Immunization Learning Exchange NILE webinar. This is Brianne Van Dyne, the Education Manager for Immunize Nevada, and I will be today's moderator. Before we get started, I'd like to review a couple of housekeeping items. First, if we should become disconnected for any reason, please call right back and we will continue. Second, please locate the Q&A box at the bottom of your screen. If you have any questions, type them there and we will address those questions at the end of the presentation. Additionally, if you have requested continuing education credits for today's webinar, please make sure that you complete the survey, which will pop up on your screen when the webinar is ended, or in the follow-up post-webinar email. All CE certificates will be emailed out within the next week. Please note this webinar is being recorded. The archived presentation and slides will be available on immunizenevada.org/NILE within 1 week. Before we begin, I'd like to provide a little disclaimer. Immunize Nevada's NILE webinars are made possible by the generosity of speakers who donate their time and expertise to benefit the coalition. The expectation and goal is for community partners to gain knowledge on immunization-related topics through a non-branded, unbiased presentation. I'd like to now turn it over to today's featured presenter, Dr. Claudia Espinosa. Dr. Espinosa attended medical school in Columbia, completed a residency in pediatrics at the University of Kansas School of Medicine, where she served as chief resident, followed by a dual pediatric infectious disease fellowship and Masters of Science in Health and Health Services Research. Dr. Espinosa also served as an assistant professor of pediatrics at the University of Louisville School of Medicine since 2012, and as an associate professor after 2018. In 2019, Dr. Espinosa joined the Department of Pediatrics Division of Infectious Disease at the University of South Florida. Welcome, Dr. Espinosa.
Thank you, Brianna. Can everybody hear me okay?
I think we're good.
Hope so. Okay. I think that we can pass the presentation. Today I am talking about reducing those missed opportunities for vaccination, and I do have a disclosure. I have been an advisor for Sanofi Pasteur, a vaccine manufacturer that does not make any HPV vaccine. I also have received grant support from Gilead and have participated in other non-HPV vaccine sponsored trials. Today, we are going to describe the prevalence of HPV-associated cancer and the effectiveness of the HPV vaccine. We are going to discuss the missed opportunities for HPV vaccination and how we can decrease those to make it more, increase the rate of vaccination, and identify communication strategies to make strong recommendations for HPV vaccination. We will review some common parental concerns about HPV vaccination and how to answer them. And finally, in the last few minutes, we'll explain the importance of maintaining routine immunization practices for adolescents and for other children during the COVID-19. So let's talk first about HPV vaccine preventable cancer. Next one. HPV is really a common infection. About 80 million people in the United States are now infected with HPV. 15 million approximately will be infected in the next year. And most of them are in the early 20s and late teens. About 43,000 people are diagnosed every year in the United States with a cancer caused by HPV, and that brings the calculations to 1 case every 20 minutes. So meantime we talk now, today, 3 people will be diagnosed with an HPV preventable cancer. Next. So which are those cancers? So for females, there are about 25 new cancers every year, and the majority of them are related, well, are in the cervix. About 18% are in the anal region, vulva about 16%, and 14% are oropharyngeal cancers. And in the males, about 20,000 of those cases are diagnosed every year, and the great majority of it, it's oropharyngeal cancer with 82%. Next. Here is the same graphic, it's just in numbers. And what this is showing us is if we take all the serotypes that are covered by the 9 HPV vaccine, and we compare with the types of different HPV-related cancer that we see every year in the United States, this is what we are gonna see, that HPV types in the 9-valent vaccine are gonna be 81% preventable in the cervix, 73% preventable in the vagina, 63% in the vulva, 57% are in the penile cancer are preventable with the vaccine or are caused by those HPV types that are in the vaccine, and 88% are caused by those serotypes that are in the vaccine. Meantime, oropharynx is only 66%, but a good number because that we saw in the other picture, that is the majority of those cases in males. And so that brings that if we vaccinate all population, then we are gonna see decrease in the number of all those cancers to 32,000 approximately. All these cancers are really histopathologically demonstrated that are the ones that are causing these infections. Next one. So now let's see what is the incidence rate by a state for those HPV-associated cancer. And what we can see is that really this is a problem of the South, right? The darker blue in the states in the South is really showing that most of the cases, the highest prevalence of HPV-associated cancer occur in the South and in Puerto Rico. So these are also confirmed histological cancer, and the rates are per 100,000 per standard population. So in Florida, for example, is one of those states that between 7.5 and 12 per 100,000 people will get infections, HPV-associated cancer every year. As we can see in this one, you can see Nevada here. The CDC didn't have the information from the state. So I hope by the next graph map, we can have some information of how good you guys are doing in decreasing that rate of HPV-associated cancer. Next one. This is a graph that is showing us the progression of the infection and how HPV vaccination can affect that progression. So here in the beginning, and I don't know if you guys can see my pointer, but most people get infected late teens and early 20s. And so as we say before, 80 million people, most people in their life are gonna be infected by one serotype of the other one. And some of them are gonna eliminate that infection. They eliminate completely, clear the virus from their bodies, but some of them do not. And from those that are infected by oncogenic cancer, those are the patients that are then gonna develop pre-cancer lesions in different places, cervical or oropharyngeal. And so here the big curve is looking at what is the incidence really of all the patients that are infected by HPV, and then how many of those are really gonna be impacted if we do vaccination on the whole entire population. So we can see we are gonna decrease the number of cervical precancer and also decrease the number of cervical cancer. And this was projection based on the results of the data until 2012. Next. And here we can see really what has happened. So in this study, these authors were looking at the pre-vaccine era. So remember, HPV vaccine was first licensed in 2006. That was the first time that the ACIP recommended it. So the pre-vaccine era that they were looking at was 2003 to 2006. Those are the purple bars. And then the early vaccine era between 2007 to 2010, those are the blue color bars. And then the later vaccine era was between 2011 and 2014. And what we can see here is that there was a decline in about 71% of infections, HPV infections, in the group of age 14 to 19 between the years 2003 pre-vaccine to 2014. And among those 20 to 24 years old, the decline in the infection was about 61%, and they were looking at the decrease in those between 2003 and 2014. This study also found that vaccine type HPV decreased about 90% for vaccinated females and about 34% for unvaccinated females. So that means that there is herd immunity, that although some people will not get vaccinated, they still will get the protection. Another reason more for us to make a really strong point on vaccination. The more people that are vaccinated, the best herd immunity we will reach. Next. And so how the decline in the precancer lesions are impacting now women between ages 20 to 30. So I told you, if the infection persists, then they will develop, they could develop, especially if they are infected with the oncogenic types, they could develop later on in life. For some people, it's really early, it's 30s when they get the cancer diagnosis, but for some other ones, it's even more later in life. But what we can see here in this trend is, and this is looking at 2000 to 2015. And remember the vaccine, and this is a study from Australia. So actually they introduced the vaccine later on, about 2008. And what we can see here is that once the introduction of the vaccine, if we pay attention to this green curve, then we can see that for the ages 20 to 24, there is a marked decrease in those patients in the incidence of precancerogenic lesions in the cervix. Now, for younger females, ages 20, then we have even a more deep decline in the curve. Next. So looking back again at all those vaccine protected HPV related cancer, there is this study that was done in Finland, in which they look at, okay, let's look at cervix, vulva, oropharyngeal, and all HPV associated cancer, and how many women really had it in the years after the vaccination. And what they were able to find was that if we compare those who get the vaccine with the ones that did not get the vaccine, right, they were able to find out that only non-vaccinated women were the ones that were having the cervical, vulvar, oropharyngeal, and all HPV associated cancer. So definitely this study proves that if people get the vaccine, if males and females get the vaccine, then the number of reduction of the cancer is going to be marked. Next. So now let's move on into the vaccine and how are the vaccination rates right now and what are some missed opportunities. Next. And so really the vaccine is not a virus per se, it's not a live virus. The vaccine is made up by this virus-like particle. It's a capsid protein that forms like a viral-like particle. And because of that, because it is not a complete virus, it's not a complete organism, there is no way that this vaccine is going to produce infection. And so because of that, of course, the vaccine is not oncogenic. So for all of those parents that are concerned about this vaccine giving their children cancer, we can definitely reassure. It's not a live vaccine. It's not a complete organism, just a part of the protein of the capsid, what it is being made of. And because of the same reason, it really produced high levels of neutralizing antibody. Actually, the vaccine produced even better neutralizing antibodies than those produced by the natural infection. Next. And so here, you remember that we had before 3 different vaccines, but now we only have 1. But this is a comparison of all those vaccines. Remember that the first one, the first one actually had 4, it was a quadrivalent vaccine. So it had the serotype 6, 11, which are very commonly produced in genital warts, and then 16 and 18, most common causes of cervical cancer. And that quadrivalent vaccine actually protects against 63% of all cancers in body parts where HPV DNA is often found, so cervical, anal, oropharyngeal. The bivalent only had protection against the oncogenic cancer, but did not have any of the genital wart serotypes because it was only 2-valent. And then the last one that was approved by the FDA in 2014 is the 9-valent, and that one had 5 more serotypes. And what those 5 more serotypes are providing to the vaccine is really 10% more protection for other cancer. So in general, we are preventing 73% of the HPV preventable infections that could give cancer if we give the 9-valent vaccine. And the immunogenicity studies and also the safety studies were so good by the time they were presented to the ACIP that in 2017 this vaccine was approved, and it was the only one that was approved because cost effectiveness will be better to give the 9-valent than just the 2 or the 4-valent. Next. So how's we got here to these new vaccinations guidelines and the new schedule? Some of you may remember still we used to do like the 3 doses for everybody, and now things have changed a little bit. So because we are now using the 9-valent, we realized after doing many studies also that if you give the vaccine early on, your body responds better. And the titers are much better that you actually will be fine with only 2 doses. So one of the things for increasing vaccination is really starting prompting parents about this vaccine earlier on. It is approved since the age of 9, actually 9 years. The first studies show that it's effective, immunogenicity is good at that age. But we say that it is on time, that we are giving it on time if we started at age 11 or 12. If we give it before 15 years of age or the 50th birthday, then females and males require only 2 doses. So this is a good way to sell it to many parents that are worried that we are giving it too early. They respond better, it's much better, the immunogenicity is better, they are gonna have protective antibodies for a longer period of time. That's what we do it at that age. And then it's really late when we give it after 15 years of age. So from 15 to 26 is still recommended as a routine immunization, and but you need to give actually 3 doses. Now, most recently, a couple of years ago, it was also part of the ACIP recommendation to make it as a shared decision for ages 27 to 45. They say that after that age, probably people had been already in contact with the virus. The effectiveness may not be as good as if we do it, as if we vaccinate early. And so you just have to talk to your patient and figure out what is the best for the patient. Next. So let's dive a little bit more into that vaccination guideline. If we give the dose between 9 and 14 years of age, so before the 50th birthday, we only have to give 2 doses. How do we do those 2 doses? Well, the first one at the visit where you are right now, and the second one will be given between 6 and 12 month schedule. Pretty wide range, and that's okay. The minimum interval in which you can give that vaccine is actually 5 months. Between the first one and the second dose. If the dose is administered less than 5 months of age or less of 5 months of time, then a third dose should be given. And so minimum of 5 months after the first dose, and if you have to do a third dose, remember minimum of 12 weeks after the second dose. If by any chance the vaccination schedule gets interrupted, you don't need to restart again. You just continue what you pick up. Next. Now, what happened for whoever comes to our door on the 50th birthday or later and they have never received a dose? Well, we still can give it. We just give 3 doses for those patients. The first one at the visit, the second one 1 to 2 months later, and the third one at 6 months after the first one. So remember, the minimum interval between the first and the second dose is really 4 weeks. If you give it less than 4 weeks, then you have to repeat it. And between the second dose and the third dose, you want at least 12 months. And between the first dose and the last dose, the third dose will be 5 months again. If a dose again is administered too soon, it should be re-administered after another minimum interval has elapsed since the most recent dose. So just take the last dose and make sure it's gonna be 12 weeks between second and third, and then you can get your vaccine completed. Next. Now there are some special situations. For example, immunocompromised patients, including those with HIV. Those patients will require 3-dose series for all ages. And we manage a lot of HIV patients, and we make sure that all of them have, because these HIV patients usually have other risk factors that are gonna make really important to have this vaccine. And so in doing the 3 doses, we are making sure that all of them get enough immunogenicity to protect them against HPV cancers. If there is history of sexual abuse or assault, start the vaccination schedule earlier. So don't wait until the 11 year of age, just start at 9 or whatever earlier is. And if you have a patient that is pregnant and you didn't know that the patient was pregnant, do not panic. There is no reason to panic. Vaccination is really not recommended during pregnancy, but it's not like MMR or any other vaccine that is alive. So there is no need to intervene or to change anything from the pregnancy. And as a matter of fact, CDC and the ACIP does not recommend pregnancy testing before vaccination. Next. Okay, so how long are we protected when we have the HPV vaccine? And it turns out that after so many years of studies, we have pretty good idea of how long these antibodies are gonna stay on. There is a pretty good study that was done with the first females that were that received the vaccine, and we were able to demonstrate that for at least 10 years, there is still good antibodies. We don't have this luxury with many other vaccines. Many of them, we really have low levels, and we just have to assume that they, at some point, if they get infected or they encounter the virus at some point, more immunity is gonna show up. But for this one, just assessing the antibodies after 10 years, it was very reassuring because these patients really have good levels, especially the youngest ones. So that's why the recommendations have changed to start earlier. Now there are multiple studies still ongoing that are monitoring like how long these antibodies can stay around. Next. So a lot of patients, a lot of parents are concerned about safety of the vaccine. We can reassure them vaccines are safe. At this moment, there have been more than 120 million doses given in the United States. And really, the safety profile of this HPV vaccine is really good. Now, of course, reaction after any vaccination can occur. They occur with any of the other vaccines too, especially in adolescents. You go figure, but adolescents faint. Adolescents have pain and redness and site reactions and swelling at the site where the shot was given. Some of them may complain of fever or headaches. And there is one absolute contraindication that we should review, and it is a previous allergic reaction, or anybody who has allergy to yeast should not have their vaccine. Brief fainting spells were really well known after a few years of the vaccine being available to the public, and that made the ACIP change a little bit the recommendations. Now, it wasn't a black box or anything like that, but they recommend, because of syncope and related symptoms such as jerky movements that could happen with other vaccines anyway, to make these patients to be sitting down or just laying down and keep them there for 15 minutes. And that's all that they need to do to avoid fainting and having other problems with the fainting, actually. Next. So this is actually what we were talking in that immunogenicity trial about the response that is given by the patients when they are given the vaccine between 9 and 14 years of age versus the response that is developed by the 16 to 26 years of age. So in the blue bars are the females and males that are young, and you can see that those bars are really high, are higher than the yellow ones, which are the response from females who were 16 to 26. So, and this is a geometric mean antibodies titer. So really, they respond really well to this vaccine, and the younger, the better. Remember that, because a lot of parents are still worried about that, starting the vaccination series too early. Next. So we have here a vaccine that effectively protects against cancer, that is pretty safe, that is pretty good. Few vaccines have such a great degree of immunogenicity. And anyway, look at the vaccination coverage. This is data from 2019 looking at the state national immunization survey team between 13 and 17 years of age, adolescents. And the best states really are the darkest states that are in the middle here, and a couple of states over here in the northeast. And the vaccination rates in those states are between 75 and 89%. Some blue ones in the west, and those are between 69 and 75 and 69. And here we find the blue ones are between 66 to 69. And then we have those clear blue ones that are 63 to 66. And finally, the other states, the white states, which there is only vaccination rate of 50%. This is data from 2018, and by this time there had been a really good amount of education and a lot of resources in several sites trying to encourage more vaccination for these teens, but still we are a little bit behind. Next. And this is the percentage of adolescents that are up to date on HPV vaccination. So the darker are 60% of graders. So you saw the first dose in the past slide, and this is complete vaccination. So in general, in the United States, probably 50% of the kids are gonna be up to date to vaccination. So it's really low. We still have a lot of work to do with this vaccine to make it really important for all of us to increase our vaccination rates. Next. So who is getting vaccinated? So here we have the breakout between the poverty status. So if you are below the poverty level, actually you have more risk of being vaccinated, 53 versus 46%. If you live in an urban region, you have more risk of getting vaccinated. So rural adolescents are being short on the vaccine more than the urban adolescents. If you are a girl, you have much higher rate of being vaccinated because we are behind with the boys still. We need to catch up with those. Next. And here it is the coverage in the United States with compared from the HPV compared with other vaccines. So here we are comparing all the vaccines that we are giving at 11 years of age, right? This continuous line is the more than one Tdap. The following is the Menatra, and it is the dotted kind of long line. And look at how good we are doing with those, right? We started increasing rates of vaccination probably since 2008, and they just have continued to soar. On the other hand, the HPV really is this one over here in the bottom. And we haven't made a lot of improvements despite the ACIP recommendation changes, which were updated in 2016 and 17. Actually, if you can see here, there is a decline in the year 2018. And we won't even look at the numbers for this year because I'm sure because of the COVID and all the constraints that had happened, then we have definitely decrease on those rates of vaccination. So as you can see, again, there are a lot to do with this vaccine. Next. And so what are the missed opportunities, right? Because in the previous slide, we saw that people are vaccinating. They are vaccinating for the 11-year-old recommended vaccines. They are vaccinating against Menactra, meningococcal vaccine. They are also given the Tdap vaccine on time. So why the other one is not given? And this is a study that we did with a big Humana data set. So all of these females and males were really, they didn't have problems with access. They did have insurance. They could have one of the Medicaid or the commercial insurance, but they have insurance. And we defined in our study that a missed opportunity was any visit that the patients will go to the pediatrician or the primary physician, and in which they did receive another appropriate vaccine, but they were not given the HPV vaccine. And looking at this huge 15,000 females were enrolled for a period of 3 years, and we started in at 11 years of age. And what we saw was that only 42% of those females will initiate the HPV vaccine before 15 years of age. And then only 37 of those who received the Tdap and the meningococcal vaccines also received the HPV at the same time. HPV was not initiated in about 70% of well-child checks between ages 11 and 15. So these were patients that were seen in a well-child check, but they got out of the office without vaccines. And 50% of the visits with pediatricians, they did not receive it either. There is some data in a previous study that has shown that maybe pediatricians will be better at administering the vaccines, but that's not what we saw during this study. Next. And this is just a graph looking at all the missed opportunities, right? So the black graphs is the visits in which HPV vaccine was given, and then the other ones were the ones in which it was not given. And look at the numbers. Most of the visits, right, the well-adolescent visits, the PCP visits, and those in which they did get the other vaccine, but they did not get the HPV vaccine. Next. So we have a problem that we have to solve. We need to make strong recommendations for vaccination and make sure that we don't miss absolutely any opportunities. Next. In this study, they asked many parents what were the reasons why they did not vaccinate their boys and females in 2016. And this was specifically for HPV. So why you didn't vaccinate for HPV your son or your daughter? And this is what they answered. Many people, some people had concerns for the safety of the vaccine. Some other ones will be thinking that they didn't need it. They were not sexually active. They didn't even know what HPV vaccine was or what it was for. But what it is really scary is that in about 15%, 20% of the cases, the pediatrician or the primary physician, the physician that they trust the health of their children, were not recommending it. So now we have to do a lot of work to try to fix that. Next. So by parental reported provider recommendation, how good that a physician recommendation does in the decision of a parent to vaccinate. And here we can see the yellow bar. It's when you as a provider recommend strongly the vaccine, then 68% of your patients will get the vaccine. When you do not recommend the vaccine, then only 35% of your patients are gonna get the vaccine. I don't know if many of you are surprised about that, because, you know, to us, and I know that I am biased because I am infection diseases physician, so I get all these difficult cases, right? But in many cases, you just assume that the parent doesn't want to do it for they did their own research, their own reasons, they talked to somebody, but in reality, many of those times is that we are not really recommending it. Next. So how do we make a recommendation? You know, this is powerful because it's in us now to make a strong recommendation. And in looking, there are several resources, good resources from the Academy of Pediatrics. There is from the CDC also very wealth amount of information, from the Cancer Society also very good recommendations. But you know, one of the things that they kind of all agree on is do not give a lot of information. To normalize the HPV vaccine, just as any other vaccine, right? You don't spend a lot of time telling them why they shouldn't get they should get the tetanus vaccine so they don't get tetanus, right? So it's the same thing, normalizing. Do not give too much information. Start early talking about it. This is an office in which we vaccinate, and at 11 years, when she comes or he comes for his 11-year well child, we are gonna give the vaccine. Be clear and be concise, and also be really confident, be strong on that what you are recommending is the best. And if they see that confidence, then maybe you get less refusals. There are very good videos, very powerful videos of people who have had vaccine preventable cancer. And all of them agree that if they could have taken away all the pain after they were diagnosed with cancer, then they will have done it. And they don't understand why people don't vaccinate their children to protect them against cancer. This is a vaccine against cancer. And that's the message that we clearly need to give to everybody. Post those videos in the office website. Make sure that your patients, your parents understand that you are a promoter of the vaccine, that your office want everybody to get the vaccine, that you don't want to miss anybody. Keep it simple. HPV infection is common. We talk about that, right? Right now, 80 million people in the United States have the infection. It can cause cancer. We saw that. And we also saw those studies in which there is decline of the cancer lesions or pre-cancer lesions and also cancer-related diagnosis. So why not to give it? Practice. This is one of those things that I saw consistently in all those videos. Practice, practice, and practice. Give it as a bundle recommendation. Say every time, today we have 3 vaccines to give. And those are tetanus, the Tdap, the HPV, and the meningococcal vaccine. Do you have any questions? As always, if there is questions. Because if there are, they are gonna take advantage of that, and that's your opportunity to provide the accurate information. Use a presumptive approach. Do not think that people are not gonna want to vaccinate. Actually, many people, many parents would like to vaccinate, but they may be just confused. They may have heard something. They may have doubts. You are there for them. So be confident about your recommendation. Avoid minimize the concerns. This is, we'll see that later, but this is very important. Just listen carefully what the parents' concerns are. Some of them are really silly. I get that. But some of them are valid because they have somebody that they know that maybe had something and they think it is related to the vaccine. And so listen to your parent and use your own personal stories because parents feel more connected. I tell everybody without hesitation, my child is gonna get her vaccine when it is the time. And actually it's coming, and she was listening to me just prepare for the presentation, and she says, I told her, you are gonna get this vaccine, and she says, it's real that is, it's preventing against cancer? And I say, yes, it is real. And so she thought for 30 seconds is what it takes her to talk, to spill something out. And she said, Mommy, I'd rather have 1 shot than 1,000 shots if I get cancer. So I'm gonna get it, even if I am afraid of the shot. And so, that's one of those things. Kids are amazing. They know actually what is best for them. So without making a lot of, stress on them, just make sure that they know that you are really confident about recommending this vaccine. Next. Here I just put together many of those videos that I thought that they were really helpful and they were really powerful. So you guys have it ready for when you want to post it in your own practices, in your own website, or you just want to watch them. Next. So the second thing that we have to do after we tell people about the vaccine is asking if they have questions, right? And when they ask us their questions, we need to reframe those questions. Usually is, I heard my friend, she got their child and she had this, this headaches after the vaccine. She fainted after the vaccine. I heard in this website, a lot of that. So it's very important reframing the question. So you have concerns about safety of the vaccine. You have concerns about the age at which we are offering the vaccine. So all those things, when you reframe the questions, they are gonna kind of understand, oh yeah, that's actually my question. And then from there, you can give a better answer to those questions. Ask also the teenagers. They sometimes will surprise you about what they think about it and what they want. And so ask them and answer their questions accurately and calmly. Don't lose your calm. Some of them are definitely not gonna vaccinate, and you don't have to lose your sleep for that. The only thing that we need to remember is that one no now is not one no forever. We can revisit, continue revisit that. Stay positive. Show that you care about the child. Show that you want the best for their child just as they want the same. That's what we do all this. Next. Now, here are some examples of how you can make a recommendation that is high quality, or another one that is gonna really bring you down your rates of vaccination. So if you take the optional approach, which was something that we really find out that a lot of providers were doing in the past, is have you thought about what shots you like today? Right? Is that optional? Because in part of the problem is that HPV is now one of those vaccines that we are requiring at schools, and so people think that because they are not required at school, they are not important. That's exactly the problem. And if you ask which ones are going to be the ones that you want today, and if you ask a preteen, right, they are going to say, well, the less the better, right? Unintentionally implies that shot is not important, or that it's good to get few of them or less than, and that has been associated with vaccination rates really low, 20 to 30%. If you give a high quality, today we are gonna give these shots. There are 3 shots in it, 3 vaccines she needs, and these are Tdap, HPV, and meningococcal vaccine. That implies that HPV is important, just like the other 2, right? And that is associated with increased vaccination rates in many studies. Next. Now, clinician recommendations really matter. In this study, they interview about 3,000 women, and whether the pediatric or the physician had recommended HPV and how strongly. And really what they show is that if we recommend and it is really strong, we can increase the rates of vaccination in about 4-fold. So that's a very good incentive to start doing that from today. Next. So again, the better that is our quality, the better that is the quality of our recommendation, the highest it is, the better rates we will have. Another thing that I kind of mentioned but didn't emphasize was the same way, same day, right? We say the same for every single patient that is 11 years of age, and then it's gonna come really natural. And it's gonna be the same way today, the same day, today. Today we are gonna get these 3 shots. Next. And the same way, as I said, is recommended the same way you do it for the other 2 vaccines. Put it in the middle. Don't let it at the last, because then people are gonna wonder. Don't emphasize the HPV, because people are gonna want more information about that. Just keep it in the middle and say the same every single time. Next. So this is exactly what we were saying earlier, right? Your child needs 3 vaccines today: Tdap, HPV, and meningococcal vaccine. And if they ask questions, then you say the HPV vaccine is to protect him against cancers and other diseases caused by HPV, which is absolutely true, and is the message that we wanted to continue propagating in every single visit. Next. And you know, there is something very important, and it is that if the provider may be doing a really good job, but if the rest of the staff is not buying into, you will have issues with vaccination rates. Next. Everybody needs to be in the same page. Everybody, since they know they are coming, or in the phone when they are making the appointment. Today, they have 3 shots. We need 3 shots to protect them from meningitis, HPV cancers, and pertussis. Do you have any questions for me? From the medical assistant or the nurse who is triaging them. Next. And if there is any hesitations, what the MA or nurse should say is, I'm sure the doctor will want to talk to you about your concerns, because we all here want to, we promote vaccination. Next. There is a really good app, and it's in the AAP information toolkit, one of the resources there. And I try it and I really like it, because it will give you different ways on how you can answer, like you can play with the different ways, and you can actually figure out how easy it is to get into the trick of being tangled in a really long conversation with just providing maybe too much information or not enough reassuring for the parents. So I would like for everybody kind of to try it. Really fun to work with and to play with. And you can see that there are also other resources that you can actually connect from the app. So it's pretty good. Next. And so this is just a play, like really, because I have only like 2 more minutes. But when the parent asks the question, just reflect on the question so they know that you are listening to them. And then ask permission to answer that question with the knowledge that you have. That always works when you ask permission for it and you're not just giving all the information that you have. Next. Provide information to change parent perspective. So being really neutral, right? With a neutral voice, tell them what is really the facts about the vaccine. Avoid arguing and rephrase what they are saying, because that way they are feeling that you really hurt them. Next. Don't get tangled with a lot of data. When they are argumentative and emotional, that doesn't work. Statistics don't work. Next. If a parent declines the vaccine, remember it's not final. Many parents will do it later. Offer material for them to read at home. And just you have done your best. Some pediatricians and providers are asking parents to sign a declination form, and that is reinforcing them that you really care about protecting them against cancer. Next. Some parents may need some more reassurance. They may need more time with you to talk about their concerns. And so they need that reassurance from you, not from Dr. Google. And so that's what it is important to be there for those parents. Next. There are really good resources in the CDC. There is a quick trainer to answer parent questions. There is also resources in the AAP that are really easy to read, and they're giving you really concise answers that you can get to those parents that are still concerned about giving the vaccine. Next. Why so early? It's one of those concerns that are really common. Well, because it's better, because they are gonna need only 2 shots instead of 3, because they are gonna have immunity for a longer period of time. Next. Is that a permission to have sex? Is another one. You probably have heard that one too. No, research has shown that the receipt of the HPV vaccine does not increase sexual activity or decrease age of sexual debut. It doesn't happen. And that has been done in many, many, many studies. So the answer is no. Next. How do we maintain routine immunizations in this COVID era? It's really challenging, right? Really challenging because everything kind of changed since we got the virus among us. And just ask me, I am a pizza ID and I haven't had really life after COVID came to Florida. So next. But there are maybe few things. We do know that there are less immunizations had been given everywhere in the country since we had these lockdowns and practices closed and all these things. Next. But there are some things that, and this is actually a graph that is showing exactly that, right? Measles containing doses are in decline, not influenza doses, right? Because we all suffer with influenza, but non-influenza doses are also in decline, and they have declined really since all this pandemic has started. Not only in children that are older, right? The adolescents here in the clear bars, those are even more affected, but also in the little ones. So we need to really try to work all together to get these vaccination rates up. Next. And so we need to continue vaccinating. There are, we need to continue, make sure, especially those infants, to do not miss any of those appointments. Next. We don't want to see outbreaks, right? Make sure you have your facility arranged in a way that you can see everybody, right? A lot of parents are worried to bring the children to the pediatrician. It's really a really good practice to tell them when they call for the appointment, we have the office set up this way, so to mitigate the risk of anybody getting COVID in the office. Next. Protecting patients and staff, right? Limited well visits, maybe to early morning, so the 6 in the afternoon, so actually your office can be ventilated overnight and you have time to clean everything. Dedicate specific clinics or buildings for those sick visits. So there are a few things that we can do to make this better, but bringing patients to our office is very important during this time. Next. Giving all your vaccines, right? If the children are really, if they have, if you have the capacity of do telemedicine, then that will work for some of those visits, not all of them. Next, reschedule appointments for families who are sick and be flexible about that, right? You don't want just the sick COVID patient to go and cough into your waiting room. Next. Create a plan. The AAP has a great resource. It's actually funny, some of the videos and information that is in the Call Your Pediatrician campaign. Use them. Use office reminders. Quality improvement projects are good, and do not miss any opportunity for vaccination. And I'm gonna leave it up to there because I am up with my time, but I'm happy to take any questions if you guys can stay a few minutes.
Thank you so much, Dr. Espinosa. And before we say goodbye, like she had mentioned, we're going to offer a little more time for last minute questions.
Thank you.
If you have any questions, please type those in the Q&A box now. While we're waiting for those questions to be typed in, just a couple of reminders. If you've requested continuing education credits for today's webinar, please make sure you complete the survey, which will pop up on your screen when the webinar is ended, and also in a post-webinar email that will go out tomorrow. Just a note, if you completed it today or complete that survey, there is no need to complete it twice. All the continuing education certificates will be emailed out within the next week. And if you'd like to view or share this webinar, the recording will be available on Immunize Nevada's website, along with information for future webinars. Please visit immunizenevada.org/webinars for those details. And I also just wanted to make a quick note. We will, I mentioned this in the chat box as well, but we will be sending out the links to the resources that Dr. Espinosa had mentioned in her presentation in a post-webinar email to registrants within the week. Also, Immunize Nevada has a really great and helpful resource in the way of shots for tots during COVID-19, kind of talking about or giving talking points for healthcare professionals and public health professionals that you can provide to parents to reassure them that it is important to continue routine immunizations during this time. And then kind of some of the practices that those individual clinics are taking to keep kids safe. So we will be sharing that as well. We did have one question come in early in the presentation, Dr. Espinosa. If a vaccine is given at age 12 and there's evidence of immunity 10 years later, how vulnerable is, say, a 24 to 30-year-old who is sexually active and not married?
I'm sorry, Brianna. Can you repeat the question? I don't think I got the whole story.
Sure. So, so if a vaccine is given at the recommended age of 12, and then there's evidence of immunity for 10 years,
yes.
Are 24 to 30-year-olds who are sexually active vulnerable?
Yeah. So you know, the vaccine really was started to being distributed widely in the United States and other countries since 2006, right? So we don't have all the information later on, but what we have seen now is that the immunogenicity is so good, right? That the antibodies are so protective after 10 years that we just can imagine that it's gonna continue happening the same in the next 20 years. And so we are really carefully looking at all those numbers, and there are still plenty of studies out there that are monitoring like how long those antibodies will last. But in comparison with other vaccines that we know, this one has a very good profile in terms of providing protection. So I will say yes, after you get your vaccines at 12, you know, there was that question earlier, how good it is gonna be at 30 when they are just starting, you know, to have their life, sexual life. And now we can say that it is really good. That study that I showed from Australia was looking, because they used different parameters, was looking at women in the 40s. And even in that, you know, even if you got it late in life, those women 40 years of age, they had less risk of cancer or less rates of cancer. And so we do think that this vaccine is going to give long protective immunity, even past by that age, like 20 years. We only have the studies for 10 years because that's how long the vaccine has been around, but we think it's going to be more than that.
Perfect. And then we had another question that came in. Do you have any advice on encouraging the uptake of the HPV vaccine, especially during COVID, since many parents are afraid to go to the doctor's office during COVID? It could be even more difficult to get parents on board to vaccinate for HPV. I know that adolescents are notoriously difficult to get in for those well checks anyway.
Yes.
So
and that, well, and imagine now that we don't have, you know, probably schools, right, for some time, or we may not have even sports for who knows how long, because sports are one of those things that are probably going to be pushed. And so yes, a lot of we are facing a lot of challenges now, but I will say there are a lot of examples of really small QI projects. Remember, when you do a QI project for something like this, you're gonna get your mock points for your recertification. So it's actually even, you know, a good deal. But you can try to do something like a quality improvement project, trying to remind these children, these adolescents or preteens to come to the office and, you know, offer them, you know, morning appointments, right? If you are healthy and you don't have any symptoms, you don't have to worry about getting any sick here in my waiting room, because only, you know, we we are waiting in the car, and I'll bring you back when everything is ready, and only healthy people our children are coming in the morning for the well child instead of the afternoon. So little things that may make a difference. Call them, show them that they are important to you, that even if they don't need the school physical, or who knows what they don't need, you are still there for them. It takes a little bit of time to try to go through, you know, records and try to figure out who has been seen last year or not, but it will pay off, because we need to be really proactive during this time. It's really hard time to try to get routine exams and routine interventions on, but we need to make the effort to do that.
Absolutely, and I'll just make a note specifically for Nevada. Our school immunization requirements have not changed due to the COVID pandemic. So regardless of whether your school district in Nevada is engaging in distance learning or in-person learning or a hybrid, those immunization requirements are still the same. So just making use of those opportunities where children are coming in or adolescents are coming in to get that first dose of MenACWY and Tdap that are both required for school. Like Dr. Espinosa had mentioned, continuing to utilize that as an opportunity for the recommendation of the HPV vaccine is incredibly important as well.
And Brianna, now that we are talking about this, I know this is not a lecture for flu, but this is the right time, right? To tell your parents you don't want your kid to have COVID. Even when the kids with COVID have done well, you don't want your kid to have COVID and flu at the same time. If you never vaccinate, this is the time to vaccinate against flu too. So very important. And you know, if you're gonna get them in the fall, then just give the 4 shots when the flu vaccine is available.
Absolutely, and we should have that available publicly, hopefully within the next month or so. And I know some of our private providers are starting to get that in stock in Nevada as well. So yes, great point to be made there as well. So we are over time, but so many great points and information. We will be posting this slide set on immunizenevada.org as well, so that you can review some of the information we were not able to get to today, because there's a lot of really great tips and resources in there as well. But we'll go ahead and conclude today's live presentation. Thank you again, Dr. Espinosa. And
anytime. Thank you for inviting me, Brianna.
Participated today, and have a great rest of your day.
Thank you.
Of course, thank you.
Okay. Have a good day.